Okay, why don't we go ahead and at least start with the introductions. So I'm Mike McKee. I believe I know everybody here. So I'm a professor at Department of Family Medicine and also direct the disability program. So it's good to see everybody. So I'm going to just go just on the order of video screens here. Philip?
I'm Philip Zazov, and I'm retired, but I used to work at the University of Michigan Family Medicine, and I'm still doing some work.
Yeah, Philip was our former chair, so he's being humble. Dawn?
Hello, everyone. Dawn Michael. I'm Disability Program Coordinator working with Department of Family Medicine.
Wonderful. And I have Michelle.
Hi, Michelle Mead. I'm a rehabilitation psychologist and a professor in PM&R and family medicine and the director of the U of M Center for Disability, Health and Wellness, where I work closely with Mike.
Wonderful. Heidi, good to see you again.
Hi everyone, I'm Heidi Joshi. I'm a psychologist just starting with the University of Michigan in a couple of weeks, and it's great to be here.
Yeah, we look forward to it. Susan?
Hi. Hi, everybody. I'm Susan Haverkamp. I'm at The Ohio State University, but managed to get invited to join these disability groups that I always enjoy. It's great to see everyone.
Wonderful. Tess?
Ms. Kirschner. I'm a senior undergraduate at the School of Nursing, and this past year I was a disability intern. Yeah.
Wonderful. And Samia?
Hey everyone, can you hear me okay? My name is Samia. I use my name or any pronouns. I'm the project coordinator for disability services on campus, so I work with Dr. Openlami.
Wonderful. Liz?
Hi, I'm Liz Katz. I'm the science communicator for the Department of Family Medicine, and I also help promote the MDisability program.
Wonderful. Brianna?
Hey everybody, nice to see you all. I'm Brianna. I'm the Disability Health Fellow here at U of M.
Wonderful. Amy?
Good morning. My name is Amy St. Amour, and I'm the Development Officer here in the Department of Family Medicine.
Thank you. Pia?
P.F. Anderson, Emerging Technologies Informationist and Disability Liaison for Michigan Medicine from the libraries.
Wonderful. Mo?
Hi, I'm Emma Lothman. I'm a family physician who supports the MDisability wonderful team.
Great. And then Tyler?
Hi there, Tyler James, Assistant Professor, Family Medicine. I focus on developmental sensory disabilities.
Wonderful. So I am delighted to have Dr. Kristi Kirschner join us today. And I know we have touched base off and on for various reasons, mainly around the medical education area. And this is certainly a major topic of discussion. How can we do more? How we can have disability health be a standard set of curricula in many of our health professional training programs. So before we go a little bit further, I want to just give a brief bio. So Dr. Kirschner is a clinical professor at the University of Illinois College of Medicine. She is at the Department of Medical Education and has a secondary appointment in the Department of Neurology and Rehabilitation. She is currently the Director of Undergraduate Education for DME and has a subtheme, is also serving as a subtheme leader for the Health Humanities and Ethics curriculum at her school. And Dawn also sent a link to get more information. So I want to turn over, and really this is intended to not only just get an overview of Dr. Kirschner's work, but have an opportunity for us to present questions, maybe share some of our efforts as well. All right, thank you.
Thank you, Michael. First of all, I'm very honored to be asked. I feel like I'm talking to people who actually have done much more work and have more expertise than I do, but I'm happy to also share what we've done and how we've done it. You'll see that our story is one of looking for opportunity to sneak things in. I, as background, am a rehab doctor, so my clinical world has been disability medicine. I've always loved caring for people with neurologic complex disabilities. I was at a well-resourced hospital for 20 years. I was in a safety net hospital for 10 years, and ultimately realized that the structures are so broken, it's impossible to try to care for patients without a full interprofessional team and health professionals who really understand how to be members of that team, how to care for people with disabilities. So in 2015, I came to University of Illinois when they were starting a curriculum reform project. And I have a background in ethics. I did a fellowship in clinical medical ethics. A lot of my life has been thinking about disability ethics. I've been in departments of medical humanities, so I took the job of trying to lead the curriculum transformation for health humanities. You'll see how disability studies became one of the first ways I began to sneak in curriculum through the Health Humanities program. So I'm going to share my screen. I do have slides. It's a lot of slides, and we're not going to I want to give you a flavor for what we've done and how we've done it. Can everyone see my slides okay? So I'm going to be talking a bit about a HRSA grant that we got because that's really provided some substantial resources for the curriculum work that we're doing right now. That will be more at the end. This is the team that we've built. It's a team across 3 campuses. These are people that have helped me create curriculum, co-teach the curriculum, have been champions of getting these materials into the College of Medicine as mandatory curriculum. Some of these team members are also part of the HRSA grant. So let me first just describe the principles. You know, how did we think about this reform work and the opportunity it offered us to sort of redesign, think creatively. We also can share with you where we are at this moment in time, but where there's still much work left to do. So when I came, I can tell you we had very little curriculum, even in ethics, which is usually, you know, a pretty core area of the College of Medicine curriculum. We didn't have a lot, and we had essentially nothing in health humanities and nothing in disability that was mandatory curriculum. So I became this theme leader, and I had to create a roadmap. That was one of the first things asked of me. You know, what's my roadmap for health humanities? How am I tying it to the learning objectives for medical schools? And I had to do this not just for the Chicago campus, but for Peoria and Rockford, because part of the curriculum reform was to make sure that they were getting the same curriculum on the same schedule with the same evaluation mechanisms. Before this, our campuses had operated fairly independently, and it was an LCME issue where we had to align our curriculum and our learning objectives and assessment methods. There were a lot of people, so we had about 150 people who were coming together, working on the curriculum across the 3 campuses. And as a person advocating for health humanities, I very quickly realized most of them don't know what health humanities is. And of course, even fewer know what disability studies is. So there was a sense of competition, you know, that I was asking for curriculum time, and people weren't sure that it was valuable enough. Maybe it could be elective or not mandatory. And so that was an initial fight, I would say, that we had to figure out what was going to be mandatory curriculum that all our medical students would be exposed to. So we wrote a statement for how we perceived medical humanities on our campus, and we quickly adopted the language of health humanities because we believe at heart this is all interprofessional work. We're focused in our health humanities programs on trying to contextualize the illness experience, human values, identities, how stories are crucial to understanding the people we work with, but also our colleagues. So this was a broad conceptualization of health humanities and allowed us to make disability a substantive part. It was also very critical that we took this interdisciplinary approach and we exposed students to the perspectives of people they would be working with. So we try to bring in people who can talk about what it's like to live with various conditions and talk about the social aspects of their lives. So we use disability and disability studies as one of the core components of health humanities. We use the AAMC PCRS framework, and these are very broad. Susan has done so much work, Susan Haverkamp, on trying to help us think about competencies and how we bring them into the curriculum. Well, we were looking for those opportunities. One of the interesting things that's been a challenge is we don't see the word disability come up very much in competency reference frameworks for medicine. It's one of the points of advocacy right now that we're not just talking about health and disease, but we're talking about health, disease, disability. But these are the competencies that we anchored our health humanities curriculum on. Here we see the word disability in the diverse patient population and the diversity of the people we care for. This issue of ambiguity in clinical decision-making has also been a very important part of our curriculum. For those of you who teach medical students, you learn very quickly that they are thinking about their first board exam. They're wanting to know what's the right answer. They're wanting multiple choice questions. That's not the way we teach this. And it's very important that we help them understand that this a lot of times are process issues, skill building. Sometimes there's not a clear right answer. We have to engage in shared decision making. So it's another piece that we bring in through our curriculum. So the faculty buy-in was a problem. The student buy-in was a problem. They weren't real excited about this curriculum because they didn't see it as helping them a lot in their immediate task at hand. We were initially treated as optional by our curriculum task force. Within a year, we were able to get that reversed and make our curriculum, for the most part, mandatory. We were very lean in terms of faculty to teach this. A lot of my work initially was to go out, meet people in the University of Illinois system, Department of Disability and Human Development, clinicians whose work interfaces with disabilities. We've got 7 health science schools, so it's been wonderful to pull broadly from all the resources that we have. I was concerned about needing to have some funds to pay people to actually help us create and deliver this content, and discovered there was something called Davis funds, which were a fund that was given back in the 1950s for ethics that had been expanded to humanities. And we've been working to leverage those funds for people who are not full-time faculty members so we can enhance our pool of teachers. Small group work has also been a challenge, and a lot of what this curriculum needs is small group activities. So we've been working hard on developing more infrastructure for small group work. So in terms of disabilities specifically, You'll see in the curriculum, we've got conceptual framework sessions where we've got a couple of hours to stretch out. Usually we do a plenary and we do small groups. But it's to provide an overview of the conceptual issues they need to understand before we get into application exercises or apply these concepts to court cases and TBLs. We teach pretty early on a disability studies framework, or WHO, biopsychosocial, whatever you want to call it, but a very integrative whole person framework of disability. We make sure that we always center the voices and perspectives of people who live with the conditions. And I've taken the approach with all of this curriculum that the more we can integrate it into the existing curriculum, the better. It doesn't need to have a neon sign that says, this is disability curriculum. This is healthcare. This is doctoring skills. And so we sneak it into all sorts of places in our block courses, which are organized by organ systems, which I will show you in a minute in terms of how we've incorporated some of it. And again, we always try to emphasize that this is interprofessional, interdisciplinary practice. So phase one, what I'm going to walk you through are some examples of how we've done this. The blue highlight is always going to be that standalone conceptual framework. Usually for health humanities, ethics, and our disability, we'll have one conceptual framework session per block. Sometimes we have more than that. The material that we bring into TBLs and court cases. So a court case TBL would be a 2-hour, 50-minute session typically. 20 to 30 minutes of that time will be given to a theme or a sub-theme, and that's where I can try to integrate material more as application exercises. And you'll see some of the materials that I put in here aren't directly saying disability, but they're very supportive in terms of the concepts that we're introducing. All of this is preclinical. That's where the bulk of our time has been made available to us. Let me pause there. We launched the curriculum in 2017. So we're well into it. We've had several classes who've gone through it. Do you have any questions of what I've presented so far?
Kristi, I do have a question. So in terms of the buy-in support, did you have a lot of that already set prior to this HRSA grant? Or was it the HRSA grant leading to additional support? How did you navigate that? Was there sort of a heads up that this grant's going in? If we get funded, this is what we're going to do in exchange for your buy-in? How did you navigate that part?
Yeah, so part of this is, in addition to working on curriculum, I've been working on developing what we call a lifespan disability center. And part of this was because then I said, my prior work in trying to care for these complex patients, we didn't have an infrastructure. So when I came to University of Illinois, I started to talk to the primary care people. Our chair of internal medicine and our division chief, we've got a strong MedPeds program, was interested in starting to help us support this effort, hired Dr. Erin Hickey, who's a MedPeds doctor fresh out of her residency, wanted to make disability the focus of her career. So in parallel, we've been trying to champion and develop clinical services for people with disabilities, which has also given us entree to other people who could be champions for the curriculum. So I would say it was gradual. It built over time. The HRSA grant has given us a leap, to a new level of attention and resources, but it was growing before that. Okay. So let me show you, I just finished last week teaching this session. So block 1 is our body systems and homeostasis, biochemistry, genetics, a lot of basic material that students have seen before. They're going deeper with it. And they do this core case where they end up with a diagnosis, a prenatal genetic diagnosis of Down syndrome. When we started, I was given 20 minutes in that core case to try to unpack the disability concepts. Within a year, they said, you know, this is not doing your curriculum justice, doing the students justice. Let's pull it out. So I was beginning to get some allies, I think, at that point. He said, really important material. We're going to give you an hour. No, we were going to give you 50 minutes. Then I was able to advocate to get it to 80 minutes. So you can see how this is like a creep factor, but it's been really valuable because these are students within their first month of medical school. They're doing genetics. They're making a prenatal diagnosis of Down syndrome. And so we do the history of eugenics. We talk about the new eugenics with new genetic technologies. We talk about vestiges of social Darwinism. We introduce them to medical terminology about intellectual developmental disabilities, how, you know, these used to be diagnoses, these pejorative terms. Now we've got terms that are preferred, and we try to get them orienting their brains to what to consider and think about. We also take them from that history into the present and talk about what's it like now to have Down syndrome. You know what, if you have a child that, you know, has Down syndrome, what could you expect now? And how does that compare to the counseling that people received 50, 60 years ago? So this is one of the first introductions our students have. And I have to say, this is one of my most favorite sessions to treat because the students also are getting a chance to begin to think about non-directive counseling and the information that you need about the lived experience, not just the medical deficit model, but what are all of the things about how we treat people that affect outcomes. In block 2, which is a block where they're beginning to do pathogenesis and talking about diseases, I do a session on understanding the difference between disease and the illness experience. And this is a great way to get them thinking about whole persons, how it's person-centered. A person with a disease, a name, may have a wildly different experience than somebody else who lives with that condition. So we have to contextualize it in the experience of the individual, and we introduce them to tools like close reading, narrative humility, empathic curiosity, because these are skills that we want them to cultivate as they're beginning to work with people with disabilities, of course, as well. Another core case then that I do in block 2 is more of a social justice, health equity case. And of course, HIV/AIDS was very important in the history of the ADA as well. So we use it as an example of stigma and bias and what happens when people don't know what's happening and there's fear and there are public health issues, why patient activism with HIV/AIDS changed the entire landscape in terms of treatment options and attention. So we unpacked that history, and they gave us 50 minutes actually for doing that. The formal introduction to disability happens in January, which is our block 3, which is our musculoskeletal block. And we basically have them do a lot of the preparatory work on the WHO definitions, some of the history of the ADA as prep work. We've got a PowerPoint that we've curated that's about an hour in length. And I also have them go to the Dread of Healthcare video website, pick one of about 20 videos representing a variety of disabilities, perspectives. They have to watch one and they have to write me a reflection. on what the problem is, defined by the person, and what they could imagine as possible ways to address it. So when they come into the session with that preparatory work, we have a panel of people with disabilities that they engage with for an hour. It's a moderated panel by the head of our, one of the heads of our independent living centers, and I've got all 3 campuses set up to do this. We talk about what independent living is, what an independent living center does. We have the moderator ask them questions about their experiences working with the healthcare system, what they wish health professionals would know about how to better care for them. In the small group, we dive into some of the social, cultural, medical trope scripts, attitudes that recur, that are often unconscious. So we do a little bit with media, film, the pity script, the superscript, the asexual, all of these different tropes, because we want to begin to heighten them to these tropes are powerful, they're embedded in society, and they also show up in the healthcare system. And they work on trying to figure out what would they do to combat some of that embedded ableism. I'm going to move a little bit more quickly here. I think you're getting a feel for what we do. But we bring back the illness, disease, with rheumatologic illness, systemic lupus erythematosus. I have a video of an interview between the patient and her doctor. She lives with very severe lupus. She talks about it, how it unfolds, how it affected her entire life, and how she's continued to try to have to adjust and make compensations for new issues as they occur. The GI bleeding one is how I really get the disability paradox and hedonic adaptation in, because the case is colon cancer. And I have the students begin to imagine, how would you counsel somebody if they've got questions about a colostomy? And you've got temporary and you've got possibly a permanent colostomy. Are those different? Are they the same? What do we know about it? How do you imagine future states that are unfamiliar to you? So this is another one where we get into, how you have to have tremendous humility and understand that if you've never lived the experience or had familiarity with it, the best way to learn is from people who have lived with the experience and understand how we can better support people in dealing with future issues that may have an impact on their lifestyle. We come back right now, I'm in the midst of our 2nd year, and that's the brain and behavior. These are students that have immersed themselves in neurology and psychiatry. And in this session, we go deep into ethics. We're talking about what does it mean to be a person? What are the major prominent legal cases in ethics that have helped define withdrawing, withholding, life-sustaining treatment of people with severe brain injury. We talk about, I use The Mango Princess. Where's the Mango Princess? A book by a woman whose husband had a severe brain injury, but she draws from his diary and talks with her 8-year-old daughter. So we talk about brain injury as a family disease and how we have to be able to meet the patients where they are and understand that, what does it mean to have personhood, personality changes in terms of behavior, and how do we navigate that? I do a total pain session. This one, again, unpacks the palliative care, 4 boxes, holistic model of total pain. And we use examples from osteoarthritis and sickle cell disease. I do a stroke case where we talk about feeding tubes, but we talk about it in terms of person level values, lifestyle, and try to help them imagine that part of their job is to not just talk about the procedure of having a feeding tube, but how is that going to affect your lifestyle, where you live, how you live, who helps you care for it. We do a dementia case, and this one gets into a little bit more of anticipating the genetic questions that can come up with future disability and whether that's information people want. We get into neurodiversity, neurotypicality in our autism case. We do MS, where I just, basically introduce them to rehab services and the whole interprofessional team and how primary care doctors should think about these people as partners as well for their care of patients. You got somebody in the hospital, you need to know whether they can walk, whether they can care for themselves before you send them home. So we use that case to help them understand the roles of different team members and how they can work with somebody with the chronic disability going forward as needed. This case on growth hormone deficiency is fun because it's a short stature case, and we talk about idiopathic short stature and when do we use medical tools for social reasons? How do we think about that? Transition to clerkship is at the end of these 18 months when they're preparing for clerkships. And this is when they do their first in-depth session of working with deaf and hard of hearing patients. And I bring in Corey Axelrod. Do any of you know Corey?
Yes, I know him quite well. I think Philip might know us. Philip, do you know him as well? Okay.
Can't see Philip's answer.
Oh, this is Tyler speaking. Yeah, I also know Corey. He's great.
Yeah, he's wonderful. And so we've got, this is groups of 50. So in Chicago, I've got 200 medical students. And so you can imagine how difficult it is to try to get the small groups going. But here we do it in groups of 50. He does an hour. We've got prep work for them. And he just comes in and really discusses a lot of the issues you have to understand about the range of perspectives, how people self-identify. The issue I'm working on right now is trying to get an OSCE, which would be formative, not an OSCE, a formative experience where students can then practice the skills of how to work with interpreters and video relay networks and whatnot. That again is a much harder lift because it requires a lot more resources, but Corey and I and one of our simulation people have developed a case that we hope we're going to be able to pilot test. But this is a very well received case. And one of the things that I can do with this case is to begin to talk to the students about their role on the healthcare team. So we do some upstanding moral distress work with them. You're going to see things and experience things that are antithetical to what you think should be happening or what we taught you, hidden curriculum. But, there are ways, even if you are the low person on the totem pole, the hierarchy in healthcare, that you can speak up and advocate to do the right thing. And that can happen with deaf and hard of hearing patients. It can happen with patients who need other interpreter services. So one of the things I coach them on asking when they're being oriented to their clinical side is ask immediately, where would you call? Who would you ask if you need to get an interpreter for your patient? Just figure that out yourself so you can be the one on the team that's starting to make these phone calls and get these resources in place. We talk about also the well-placed question that if they see somebody cutting corners or taking shortcuts, not using a medically certified person, you trying to pull in a family member or somebody who's not a trained interpreter, to pause and say, I wanted to ask, is that proper? Shouldn't we be getting a certified, a trained interpreter, being the one on the team that asks the question? So, not all of our students feel immediately comfortable. So then we talk about who else can you call? Who can you talk to if you have concerns about the quality of care? In our clerkship right now, we're pilot testing some ethics, moral distress groups, and we want the students to bring those experiences to us. We're just trying to get an hour in each clerkship and have them unpack them. When we get into phase 3, we've got electives. So, medical humanity elective, perils of the normal, unpacking these concepts in literature, history of disability, medical historian, psychiatrist with the background in medical history does one on psychiatry, culture, and sociology. And the last one is by our medical anthropologist, David Ansari. We also have rehab rotations that are electives, and now this disability elective that we just started, which we're very excited about. So we got this HRSA grant. It's 5 years, and it was to develop a medical student elective in disability inclusive care through primary care. So we've been working on the Lifespan Disability Clinic. We have 2 locations. One is the preferred location because it's fully accessible. The other site is still more of a small clinic where patients who don't need the accessibility features can go. But we're really pushing our Gage Park site with our interprofessional team. And the students rotate 4 half days in 2 weeks through that particular clinic. We also send them to an autism, developmental disability, childhood clinic. We send them to assistive technology clinic to see seating and positioning in the home that's comprehensive with home modifications. We do language assistive technology where they can look at how different patients use high-tech, low-tech devices. We are looking at a ventilator transition program and a dental clinic and a rehab spasticity clinic. So they're getting those clinical experiences. We also have day in the life experiences with a number of patients, and we're doing videotapes actually. So we've got a library, a catalog of introductions to people and follow them through their lives, going to work, doing recreational activities, taking transportation, coming to a doctor's appointment, and talking about, what it is they value in their relationship with their health professionals. We're developing 20 educational modules. They are currently in progress. They're going to take a whole lot longer than we had originally anticipated, but we're going to make them all free of charge on a publicly facing website, and we're trying to make them as interprofessional as possible. So we're not using the language of doctor, we're using the language of clinicians, and we're trying to be mindful, of a broad interprofessional audience. And the patient instructor simulation. So we created 2 very simple cases, and we have 8 patient instructors, 4 with physical disability, 4 with intellectual disabilities, intellectual developmental disabilities, because that was the focus of the HRSA grant. And so each of our students who rotate through do both of the core cases. They're formative. They get feedback from the patient instructors, and the patient instructors, other than the scenario, play themselves. They're being authentic in the interaction with the individual. So I'm going to just close here so we can talk a bit. The sustainability, a lot of this, I'm afraid I'm still the primary person teaching a lot of it. I keep trying to build my team, my faculty resources, work with other people to get them comfortable so they can take over, particularly for their campuses teaching. I think that we need more programmatic support for running the curriculum. There's a lot of admin moving pieces to this. And as you get into small groups and you get into having to coordinate stipends for the people who are coming to work with you from outside, there's just a lot of admin, and I need more support for that. We do have some assessment and evaluation mechanisms, but a whole bunch of our work over the next 4 years now will be focusing on how do we know whether it works. We'll be tracking our people who go through the 2-week elective longitudinally. We'll find out, how they end up using it and whatever they choose to do. whether it was valuable, getting feedback on what they would recommend we add or change. There's always going to be competition for time in the curriculum, but again, I think the strategy has to be, how do we partner with existing curriculum? We're trying to do more partnering with our docs course, which is our clinical skills training, our communication skills. And I think that is a great way for us to go. You know, we don't have to have standalone curriculum. It can be partnered curriculum. So that is what we're doing. Let's see here.
Kristi, so we have a few comments in the chat, which we'll read out. And Philip, do you want to go ahead with your question and
Sure,
I'll open the chat?
I'm sorry I missed your question before. Yes, I've met Clary. I just want to say, Kristi, I'm impressed with what you've done. This is not easy stuff that you've done, and I'm just impressed with your persistence, and this is really important in making it happen. I'm wondering, one of the things I found most at Michigan is people pay lip service to this area, but they don't really understand. And I think part of it is because it takes more time to care for people with disabilities than it does somebody who doesn't have that. I'm wondering if you have any thoughts about how you overcome that. I don't think people do it deliberately throwing a barrier, but I think it's just easier not to go to say yes, but not to do anything. I'll give you an example. I tried to get the institution to provide door openers, automatic door openers for people in wheelchairs in the institution. In many places, they wouldn't do it because it's, quote, too expensive. Anyway.
Yeah, I think, well, first of all, we are going to have some help with the new rules and regulations from the Section 1557 Affordable Care Act and the new rules for 504. So actually, healthcare systems are going to have to all have wheelchair accessible weight scales and accessible exam tables within 2 years. And if they buy new equipment, they're going to have to use the new accessibility rules when they're doing purchasing. That's huge. And not only are they posting these new rules, but they're going to have some enforcement. You know, the ADA was not self-executing. We had to wait for people to lodge complaints. Now we're going to actually have drop-in site visitors who can do some audits. So I think that the anti-ableism training is also going to become part of what healthcare systems are required to do. So, you know, I don't love the law having to be our stick, but we are going to have a few more sticks. Now, when you look at, you know, how people understand disability, I think that oftentimes we've made it, you know, those patients out there, you know, and you look at the disability that's in your healthcare system now, in your primary care practices, your aging patients, your, you know, so trying to capture how much disability is actually already in what we do, and we're not doing a very good job, the patient safety and quality issues. So I've really liked this lifespan disability clinic because we developed a consult service. So Dr. Hickey gets consults all the time from people on the inpatient side saying, this patient was, you know, a Medicaid patient auto-assigned to me. I have no idea how to take care of them. They're no longer in the pediatric care system, but they don't have anywhere to go. So we're trying to be helping them and partnering with our hospital resources on giving them tips and tools. Somebody on this call was a disability resource coordinator. That was Dawn. I think that identifying your disability resource coordinator and just slipping in, you know, more tools and resources helps a lot. I still find I cannot get the attention of people at the very top, people who control the resources. So a lot of this is happening in a subterranean fashion, but we have found our allies and we're making progress. So, I wish I had a better answer because I
No, thank you.
oftentimes,
Thank you.
yeah, people, when it touches them or their family, the interest goes way up. But I think we have to help them see it in their current lives. And they may not think of that patient, as having a disability, but if they've got osteoarthritis and they can't climb up on your exam table, or they're sitting on that exam table trying to get off, they fall and hurt themselves. Patient safety quality, has to be part of our messaging here.
I like to say that every one of us will probably get a disability at some point in our life. I mean, obviously I have one as a baby, but even if you're quote unquote totally able, at some point something can happen. And so this is actually one of the biggest things we can do, is figure out how we take care of people with disabilities. But thank you. I'm talking to the choir, I know.
Thank you, Philip. Thank you, Kristi. So just briefly in the comment, the chat box, I know we have one talking about Samia mentioned my pharmacy friend ran into that issue during her residency in Detroit. Nobody she worked with knew how to contact ASL interpreters. There are resources to at least connect with the RID, which I forgot to put in the chat box. But yeah, big issue, just having good intentions, but just don't know how to do it. So I know there are resources out there, but they are hard to find. I also have another one from PF saying, would it be possible to request a copy of the slides, even as a PDF? If you're comfortable, we can.
I'll try to
Okay.
drop it in chat while we're talking here. So absolutely.
Okay. Yeah, and also feel free to reach out to Dawn. She can also circulate it.
Okay.
And let me see if that's everything. I just put a couple of resources in there. One, what's a deaf hard of hearing training packet for clinicians, as Susan was the lead on that. And there's also a video from Deaf Yes, led by Dr. Melissa Anderson, who's another really great champion in this topic. So Brianna, go ahead and why don't you ask your question? I have a few other questions too. Go ahead, Brianna.
Okay, then I don't want to get too off topic because I know the focus of this talk is on medical education, but I do think part of that is having a clinic for medical students to rotate through. And so I'm just curious in about how your institution leadership supported the development, or if they supported the development of your specialized clinic, and if you used any grant funding to get that off the ground.
Doing lots of fundraising. Okay, so I'm not going to be sanguine about, the fact that a lot of my time is spent trying to get funding to develop the components. We got to prove the model. Most of these patients are Medicaid. Most of them take extra time. They require lots of social work support, which, it's not billable. These are things that we have to be able to provide proper care. And we got an innovation office here in Medicaid where I've been talking to them about what information do I need to make the value-based care argument for our payments. We got to restructure the way we've done this. So we have actually a national working group that are thinking about particularly the problem of pediatric developmental disabilities aging into adult care. 85% of that population is aging into adult care. They have nowhere to go. PEDS has done a good job overall managing them, but by the time they're adults, they're getting adult care. So they're ending up in primary care clinics that aren't equipped to care for them. So we are doing fundraising for the Seating and Positioning Clinic for a dedicated social worker. The chair of internal medicine hired this doctor and has supported her time to give her extra time for the appointments. We've got 2 new doctors that just started. One is only a half day a week and the other is 2 half days a week. Molly Fasoni, some of you may know, has quadriplegia, just finished her internal medicine fellowship she was chief resident at Vanderbilt. We've got another internist who did sleep medicine and knows how to work with non-invasive ventilation. So we're trying to bring in people with disabilities to also help change the culture. But the way I pitched it is 3 to 5 years, collect the data, prove the concept, and then do pretty aggressive negotiation. Because if we can show we get better quality outcomes and prevent preventable complications, then, I think that's going to help us continue grow. The really hopeful piece of all of this are the young doctors that I'm working with. I have never had more medical students who want these experiences, who want to, rotate, learn, do it right. They are chomping at the bit for more. I've got a group this week that asked me if I would be their faculty advisor for an ASL deaf and hard of hearing sign language group for medical students. They want to learn how they can take better care of this population. So I feel like that also is something our leaders pay attention to. When students are asking for something, and saying, we need this, that helps a lot. The fact that MedPeds and Family Medicine, Philip and Michael, you have done such a great job, with centering a lot of this care in primary care. I'm a little disappointed at times with the world of rehab because I really thought we could be primary care team captains for this population, working with our colleagues in internal medicine, but we lost that battle and we're consultants. That's fine. We can be part of the team. So I think developing a fellowship eventually in complex care based in family medicine, nursing, MedPeds would be a really wonderful goal to think about. You guys have also, I have to call you out in terms of the work of Lisa Meeks and the work you've done with disability and training of health professionals. That has galvanized the culture and the world that we're living in. And I think the more we bring people with disabilities into our healthcare spaces, the more culture will inevitably change.
Thank you. So I have a couple of other questions. So I really love the fact that you've engaged a number of individuals with different types of disabilities to be sort of the educators, to be in the forefront of this curricula. So wanted to kind of explore a bit more because some of these individuals, there may be a need for arrangements for transportation, interpreter, there's some combinations. And I've had some struggles navigating that, just figuring out coverage. We're supposed to cover it, and it takes a lot of bandwidth and a lot of energy on my part to just even try to navigate those areas, which is unfortunate because a lot of people start to feel like I don't want to get into that area. And that arose a lot of these really wonderful opportunities. Like you said, the students crave it. I also definitely sense that here in Michigan Medicine with our medical school. Thoughts about that? Because I know you're currently funded with HRSA, but it's, again, the sort of next step, the non-HRSA items, the future.
Yeah, so with I feel blessed in some ways that I'm at a big public university with very strong disability resource coordinators and a cultural center. So if I need anything for a student, the university is committed, to making sure that we work through our DRCs and we get the accommodations in place. The place that I think is toughest, Mike, is the clerkships that we don't control. So, if we've got students go all over the city of Chicago, and these relationships, they're responsible for providing the accommodation at their site if we send a student to them. And there's a war going on trying to get enough spaces for student trainees in healthcare systems. There's some places that are paying lots of money to get their students in. So, we also have to be mindful of the fact that if we press them too hard, they'll say, oh, we got plenty of other students. So I think that's going to be the real biggest challenge for many, but being a public university with strong DRC, I feel like I haven't had to fight a lot to get what I need for the students. I don't think that, like you said, the door switches, the high-low tables, the wheelchair skills, we haven't done enough to integrate that mindset into healthcare purchasing. One of my hopes is, with all of these new rules and regulations, that we can begin to get hospital executives interested in trying to learn more and have tools to help them make the transformation that they need to make, because there's just, if they say, well, where would I go? How do I find this out? Where's the anti-ableism training? We got to help create those materials and make it easy for them.
Thank you. We have time for one more question, and then we'll just give a couple reminders for upcoming events as well. Michelle.
Thank you. I guess I get two-part, just mentioning, I do think there are opportunities here to partner with the ADA centers and their knowledge translation to do outreach, to do training related to ADA, 1557, other accommodations. But I was wondering about how you see, I guess, the role of peer mentors who do work on self-management or who do work on, health promotion as part of either the training or as patient navigators, as being integrated to these systems.
I'm a huge fan. And we're trying to also incorporate that in our lifespan disability clinic. We got funding for a part-time community health worker. I think it really needs to be a person with a disability who knows all of the community disability resources, right? So I think that we have to figure out how to leverage that in the curriculum. I think that, having peer mentors who can also be available. We've got a disability interest group. We've got, students who are pulling together the topics and the information, and they're helping people navigate if they've got questions about, what is DRC and how to do the accommodation process. So I think it's a really empowering model, and it's one that I think we should really adopt.
Thank you so much. So we're at near the end of the hour. Thank you so much, Kristi. Appreciate joining us. A lot of great things, and I'll certainly follow up just to see if there's opportunity to synergize. I know one of my hopes is to even have students go at different universities, and maybe we can have like a swap program too. So just a couple of updates. We have our next MDisability meeting on October 10. Erin Mess is going to be presenting. She's coming from the Equity, Civil Rights, and Title IX office. I think her topic is overview of what they do, training resources. So kind of see what we can benefit from their services and so forth. We will have grand rounds in Department of Family Medicine with Dr. Sarah Mohidan. And she will be talking a little bit about her programs that she has and how to actually work better with primary care doctors and psychiatry, just to address a lot of the basically behavioral health needs for patients with disabilities. And we also, I saw a couple of things for proposals for the Disability Scholarship Initiative. There is a meeting that's already been set by Andy at CDHW. If people are interested, it's a brainstorming session to talk about different topics. I know many people are thinking about ideas. There's 2 different proposals that are out. There's a link already in the chat box. So those are the items. Dawn, anybody else have any other updates?
I just want to let everybody know that we will get the recording together, Liz and I, and get that out either tomorrow or early next week. And we can include Dr. Kirschner's presentation.
And I'd like to just mention, we do have the Disability Research Symposium coming up on Friday, October 18th. We're working to finalize the agenda and schedule now. That is a virtual event, and we have a Native Americans with Disability panel coming up in November, and of course our MLK Day event coming up in January. So please, we're going to keep in touch and let you know what's coming on from the Center for Disability Health and Wellness perspective.
Okay. Thank you, everybody, for joining.
Thank you.
And bye.